Hello, my name is Monica Mahoney. I am a clinical pharmacy specialist at Beth Israel Deaconess Medical Center. I work in the outpatient infectious diseases clinic and also with our OPAT program. In this presentation, I will review the data for the use of zinc, specifically as it applies to SARS-CoV-2 or COVID-19 as part of the Society of Infectious Diseases Pharmacists COVID-19 resources. Zinc is a mineral and is considered a trace element. Zinc is involved in many different functions and components of cellular metabolism. It is required for the catalytic activity of about 100 different enzymes in the body. It is also closely related to immune function, protein synthesis, wound healing, DNA synthesis, and cell division. Clearly, without zinc, life as we know it would not be possible. The recommended daily intake of elemental zinc differs based on sex and age of the patient. For adults, the recommended intake is between 8 and 11 milligrams per day. Zinc is relatively safe with high upper intake levels. Adults can tolerate up to 40 milligrams of zinc daily before experiencing adverse effects. After several days or weeks of higher zinc intake, patients can report mild adverse effects such as nausea, vomiting, diarrhea, decreased appetite, abdominal cramping, and headaches. Repeat ingestion of 150 to 450 milligrams of zinc per day can result in more chronic or severe effects of decreased copper levels, altered iron function, and decreased immune function. Note that these values pertain to the amount of elemental zinc. There are no standardized range of serum zinc levels to check. Both zinc deficiency and zinc overdoses are determined by clinical findings. Several formulations of zinc are available, with the most common including gluconate, sulfate, and acetate. They all differ in the amount of elemental zinc they provide. Shown here are the different salt equivalents to deliver 1 milligram of elemental zinc. Over-the-counter zinc lozenges are usually the gluconate salt, and on average, one lozenge contains 13.3 milligrams of elemental zinc. A 220 milligram zinc sulfate tablet or capsule, another common formulation, provides 50 milligrams of elemental zinc. Zinc is closely related to immune function. A 2007 study showed that supplementing zinc in the elderly could restore immune function. Infection rates were lower in the zinc supplementation group compared to placebo. The most common types of infections reported were colds, upper respiratory infections, fever, or flu, with no difference among infection types between the two groups. Colds are caused by a multitude of viruses. While rhinovirus is the most common, coronaviruses are also involved. Since zinc lozenges worked on colds, can zinc also work on coronavirus? In 2010, in vitro studies were performed with zinc in the original SARS virus, SARS-CoV. Using Vero E6 cells infected with SARS-CoV, the authors investigated the role of zinc in pyrithione on virus replication. Pyrithione is a zinc ionophore. It facilitates zinc transportation intracellularly, therefore increasing intracellular zinc concentrations. The authors found that as the intracellular zinc concentrations increased, by increasing pyrithione concentration, SARS-CoV replication was inhibited. The RNA synthesis of SARS-CoV is catalyzed by an RNA-dependent RNA polymerase called RDRP. The zinc inhibited RDRP elongation and decreased template binding. The end result was inhibition of SARS-CoV synthesis. In 2014, an in vitro study found that chloroquine was also a zinc ionophore. Chloroquine enhanced intracellular zinc uptake in a concentration-dependent manner. Additionally, the zinc enhances cytotoxic activity of chloroquine. There appeared to be a synergistic relationship. For additional information regarding data on the use of chloroquine and hydroxychloroquine in SARS-CoV-2, please refer to the other SIDP reviews. There are several proposed manners in how zinc can interact with SARS-CoV-2. Most are theoretical and are lacking evidence. 1. Zinc may improve pulmonary cilia morphology and increase ciliary beat frequency, improving mucociliary clearance and removal of particles. 2. Zinc can inhibit RDRP and block SARS-CoV synthesis, as we previously discussed. 3. Zinc may have a role in upregulation of interferon alpha production. 4. Zinc may have anti-inflammatory activity through a variety of mechanisms. 5. If the patient is co-infected with Streptococcus pneumoniae, zinc may modulate bacterial homeostasis. 6. And lastly, risk factors for increased COVID-19 mortality seem to overlap with the risk factors for zinc deficiency. Zinc supplementation may be beneficial in modulating some risk factors. Again, many of these pathways are theoretical, and there is limited to no evidence supporting these claims. What about actual data in patients infected with COVID-19? A prospective observational study measured fasting serum zinc levels in patients infected with SARS-CoV-2 and healthy volunteers. The median zinc levels were much lower in patients with the disease. The authors then split the patients with COVID-19 into whether they had normal or low levels of zinc and compared outcomes. They received the same therapy against COVID-19. Patients who were zinc deficient appeared to have more complications compared to patients with normal levels. There were additional differences seen between the groups, although most were not significant. Thus, would repleting zinc in patients diagnosed with COVID-19 impact outcomes? A letter was recently published in Chest retrospectively reviewing COVID-19 positive patients at one hospital. 196 patients who received zinc as part of their treatment regimen were compared to 46 patients who did not receive zinc. Although this study was not randomized, demographic information and severity of illness was well matched. Receipt of additional therapies, however, was not. Patients in the zinc arm were more likely to have received hydroxychloroquine, lopinavir-ritonavir, interleukin-6 receptor inhibitors, or steroids. The authors attempted to account for this by utilizing inverse probability weighting and a censorship model to estimate the effect of zinc on survival. However, zinc did not appear to have any effect on survival. Using inverse probability weighting with multivariate Cox regression, the authors did seem to find an increased risk of in-hospital mortality with older age, male sex, and higher severity of illness. Receipt of an interleukin-6 receptor inhibitor appeared to decrease in-hospital mortality. The authors concluded that there did not appear to be a causal association between zinc and in-hospital survival among COVID-19 patients. However, they do caution about the many limitations of this study. A second study, previously available as a preprint, investigated whether the addition of zinc sulfate to azithromycin and hydroxychloroquine had any impact on hospitalized patients diagnosed with COVID-19. Remember that hydroxychloroquine acts as a zinc ionophore, increasing the uptake of zinc. The authors retrospectively looked at patients admitted with a COVID-19 diagnosis between March 2nd and April 5th. Around March 25th, the hospital incorporated zinc into their treatment recommendations. Therefore, they compared 521 patients who received hydroxychloroquine and azithromycin to 411 patients who received hydroxychloroquine, azithromycin, and zinc. Patients were well matched. In the univariate analysis, the addition of zinc to hydroxychloroquine and azithromycin did not affect hospital length of stay, mechanical ventilation duration, average or maximum oxygen flow rate, or average or maximum FiO2. On bivariate logistic regression analysis, however, there was a decrease in mortality or transition to hospice, a decrease in need for ICU care, and a decrease in invasive ventilation. But when further investigating the decrease in death or transition to hospice care, it was discovered that this was mainly driven by a non-ICU population, meaning that if the patients were sick enough to require ICU care, the addition of zinc did not impact mortality or transition to hospice. Additionally, while the authors attempted to adjust for time, zinc was not added until several weeks into their pandemic surge, and knowledge of the disease could have impacted care. Therefore, there is time bias concern. The authors commented on the number of limitations, the biggest being that this was a retrospective observational study. But they concluded that the addition of zinc to hydroxychloroquine and azithromycin decreased mortality in a non-ICU population. They hypothesized that zinc could potentially prevent the progression to more severe disease. But once a robust inflammatory response occurs, such as the cytokine storm, the addition of zinc may no longer prove to be beneficial. The authors concluded that this study alone should not be the basis for clinical practice, but rather would support randomized controlled trials. We finally have a prospective randomized trial. The COVID A to Z trial randomized adult outpatients diagnosed with COVID-19 in a 1:1:1:1 ratio of 8,000 milligrams of vitamin C divided in 2 to 3 daily doses, 50 milligrams of zinc gluconate at bedtime, both therapies, or usual care that did not include either of these. Patients were asked to track their symptoms weekly until day 28 using a 3-point scale. Originally, only the bolded symptoms were screened, but 6 weeks into the study, it was amended to include all 12 symptoms. Patients were also asked about any hospitalizations, adverse effects, and additional medications. Enrollment was slow. After 214 patients, or 40% of the total 520 patients were enrolled, an interim analysis was performed. The Safety Monitoring Board recommended the study be stopped for futility. Overall, patients were well matched. The primary endpoint was a time to a 50% decrease in symptom severity from the peak of severity. For patients in the vitamin C arm, this was 5.5 days. For zinc, this was 5.9 days. For dual therapy, this was 5.5 days. And for the usual care, this was 6.7 days. There was no difference among arms. Additionally, the number of hospitalizations or death did not differ among the groups. The authors concluded that the addition of vitamin C, zinc, or both did not shorten the duration of symptoms associated with COVID-19 infections in ambulatory adult patients. As of December, there are 16 trials registered investigating zinc's role in COVID-19. 11 trials are for treatment and 5 are for prophylaxis. In most, zinc is used in combination with other agents. Several studies have multiple arms and only one of the arms is shown here. The trials are in various stages of recruitment, so please refer to the website for the most updated status. Zinc dosing and toxicity was previously discussed. In the pending clinical trials where zinc doses are provided, they are above the tolerable upper intake levels. But if these doses are only taken for the 5 to 10 days as proposed, side effects should be minimal and tolerable. Fortunately, there are very few drug interactions with zinc. Zinc is a polyvalent cation, therefore care must be taken with oral co-administration. Some of the medication classes that should be spaced out from cations include some antiretrovirals, in particular bictegravir, dolutegravir, elvitegravir, and raltegravir, and certain antibiotics such as quinolones and tetracyclines. Please refer to the specific drug monographs to determine how many hours in between doses are required for optimal drug absorption. Additionally, certain diuretics, such as chlorthalidone and hydrochlorothiazide, can increase the urinary excretion of zinc. And lastly, high levels of iron may decrease zinc, and high levels of zinc may decrease copper. Again, this is usually seen with prolonged zinc doses of 150 to 450 milligrams per day. There are several COVID-19 guidelines published by national and international organizations. At the current time, zinc is not mentioned in the IDSA, World Health Organization, SCCM, or NICE guidelines. The NIH guidelines comment that there is insufficient evidence to make a recommendation in the treatment of COVID. They further comment that if zinc is to be used for the prevention of COVID, the dose should stay within the recommended daily allowance unless the patient is enrolled in a clinical trial. In summary, zinc is a trace element, and there is evidence that zinc may restore immune function. When combined with certain ionophores, zinc uptake into cells is increased and may provide additional benefits. 2 retrospective studies have not shown appreciable benefits of adding zinc to COVID-19 therapies. Additional studies are pending. No large treatment guideline recommends zinc in their COVID-19 treatment algorithms. However, let's take a step back. Zinc is readily available. It has a relatively wide safety window with minimal adverse effects and drug interactions, as long as the dose is below the toxic range. Therefore, administering zinc should have minimal negative effects, but the larger question is whether the administration of zinc will have any beneficial effects. Thank you for listening.